Hi and welcome back to another video of Medic Notes. This video is on bleeding peptic ulcer. Peptic ulceration is responsible for 44% of all UGIB. Esophagitis and gastritis or erosions account for a further 44%. Clinical presentation is hematemesis, melena, or rarely blood per rectum. Rockall score is a scoring system developed to assess the risk of rebleeding and death in acute upper gastrointestinal bleeding. It is based on clinical and endoscopy findings. This table shows the Rockall score. Look at the patient's age, any presence of shock, comorbidities, endoscopic diagnosis, and any major stigmata of recent hemorrhage. Patients with initial Rockall score of 0 should be considered for early discharge without patient investigations, whereas patients with score more than 0 should have an endoscopy. Major stigmata of recent hemorrhage are pulsatile or oozing bleed, fresh clot or adherent clot on ulcer, or visible vessel. For management of bleeding peptic ulcer, assessment and resuscitation. Shock patients should receive prompt volume replacement. Red cell transfusion should be considered after loss of 30% of the circulating volume. Endoscopy is the first-line investigation and can identify and treat the bleeding point, and should be performed within 24 hours of the initial presentation. Injections include adrenaline, ethanol, and varicose sclerosants. Heater probe, clips, bipolar electrocoagulator, and laser. Medical management. Acid suppression, maintain intragastric pH more than 6 to stabilize clots and prevent rebleeding. PPI significantly reduce rate of rebleeding and need for surgery. We can give IV esomeprazole 80 mg bolus then 8 mg per hour infusion for 72 hours. Other meds are tranexamic acid and H. pylori eradication. This chart shows the management of upper GI bleed. Resus the patient. Take necessary bloods and transfuse blood if necessary. After patient is stabilized, endoscopy to look for cause of bleeding and for therapy purpose. Look for endoscopic stigmata of hemorrhage. Watch out for rebleeding. Next, if there is rebleeding after endoscopy, repeat an early endoscopy if initial endoscopy was suboptimal due to difficult access or poor visualization, or if rebleeding is life-threatening. Indications for emergency surgery for bleeding peptic ulcer. Absolute indications are continued bleeding or spurting vessel at endoscopy that is not stopped by adrenaline, or lesions that invariably rebelled. Relative indications include 1 rebelled in hospital or 2 rebleeds in patients aged less than 60. Or transfusion requirements more than 4 or 6 units, or if there is shortage of whole blood. Principles of emergency surgery. Stop bleeding by underrunning bleeding vessel with a suture. Conservative or definitive surgery depends on patient condition, surgeon experience, cause of ulcer, and any previous medical treatment. Definitive treatment for bleeding duodenal ulcer will be vagotomy and pyloroplasty or proximal gastric vagotomy, whereas definitive treatment for bleeding gastric ulcer will be resection of ulcer to prevent rebleeding and exclude malignancy. In some very large or persistently rebleeding ulcers, a distal gastrectomy with Billroth 2 or polio reconstruction may be indicated. That's all for this video. Thank you.